Okay, we can start for the second half of this lecture. And according to physiology, I hope you are not too much in prevalent vagotone, because it will be very dangerous. But I will try to compensate your physiological prevalent vagotone through my prevalent constant sympathetic tone, my adrenaline storm, so I will keep you under control. Before going to what did we learn from 10 years of research, I would like to try again to show you that video about two cells talking to each other according to the crosstalk mechanism between cells, sending messages through signaling molecules. It's really amazing, and you will see one cytokine passing through this microtubule embedded in the extracellular matrix from one cell to another cell. You can understand that if the extracellular matrix where these microtubules are embedded is not plastic, they will be sclerotic, and the communication between cells will be not active. So if we can try to see it again, because really it's moving for people like us who love this type of stuff. You have to, okay. These are the microtubules, different projections, and these are cells. So we have a net. Okay, look this little white spot is a cytokine passing from this cell to this other cell. That's amazing, because till 1 year ago, we only could imagine this kind of crosstalk between cells. This is reality. So I'm sorry if I'm stressing every time the audience about the importance of have a plastic matrix, but that's really crucial, and that's the reason why Guna matrix is so fundamental in every protocol that normally we prescribe. If you want to show it again, so we will see exactly the passage of the crosstalk between the cells. Yes. Okay. Don't touch anything. That's fine? Okay, good. Look, this is the passage. For me, it's really amazing, because I dreamed about that for many, many years. And it was real. It was exactly that way. So it's beautiful. Once again, this is the demonstration that Mother Nature is perfect. Mother Nature never is wrong. It always does the right thing. If Mother Nature gave us the extracellular matrix, we have to take care of it. Important, the origin of this video is Nature, the very famous journal. Okay, thank you very much. Now I'm going to present to you some of our studies, and I thought that a nice way to do that was to highlight some specific topic in this kind of research. First of all, we understood that it is possible an overlapping approach in every disease, meaning for overlapping approach, the possibility to combine allopathic medicine with low-dose medicine. It's possible to combine homeopathic and homotoxicological medication with single cytokines. It's possible to combine acupuncture with low-dose medications. Just think of Guna matrix in acupuncture. Where do you put the needle? In the extracellular matrix. If you have a toxic matrix, the effect of the needle could be less than if you will have a drain detoxified extracellular matrix. Anyway, the word overlapping, I think, will be the basic word for the future of medicine. We learn that it is possible, thanks to the low-dose medications, long-term treatments. For instance, you are going to see in rheumatoid arthritis, in order to keep low the disease activity. I mean, if you have a patient with an active rheumatoid arthritis, I'm sorry, but you have absolutely to think of biological or conventional synthetic DMARDs, meaning for DMARDs, disease-modifying anti-rheumatic drugs, monoclonal antibody, like Humira, anti-TNF-alpha, or conventional synthetic DMARDs, such as methotrexate. But you know that these kind of medications, even though they are very effective, they are accompanied by a very severe cohort of side effects. So why not sometimes to approach the patients with the conventional DMARDs to pass to the low-dose medications? And this is what we do. We learn that it is possible to fill in the therapeutic vacuums that for many diseases we always have to face. Our experience, for instance, in vitiligo. Doesn't exist any therapy for vitiligo. Just think that the dermatological world community considers as gold standard therapy for vitiligo the microphototherapy, narrowband, UVA, UVB, 311 nanometers. That's the gold standard. Yes, sometimes they recommend also, since vitiligo is an autoimmune disease, the use of immune suppressors. But immune suppressors are accompanied by severe side effects. Or even think of those poor kids that have recurrent respiratory infections. Doesn't exist any effective immunostimulating therapy. We can help these kids. For instance, we will see thanks to cytomix, and I will show you our very recent work for that. We learned that's a very biological, this is something very homeopathic, the carryover effect. For those of you who are used to be involved in clinical research, the carryover effect is that effect that we observe even after stopping the administration of the drug. And we see the patient improving, even though he's not more taking the medication. Carryover effect. That's very usual using low-dose medicine because thanks to the physiological low dose of signaling molecules, we are able to restart some bioregulatory process inside of the cell. That's the reason why, even though after 5-6 months you stop the administration of the therapy, the patient keep on improving. Carryover effect. For each one of these points, I will show you some works. We learned that exists a sort of biological intelligence of low dose, as well as high dosages of many medications are completely stupid because our cells are programmed to understand that kind of volume, which is the low dose. So the intelligence, the biological intelligence of these low doses. We learned that the combined use of cytokines is more effective than the use of a single cytokine. We are understanding in these days that using low doses of substances, there is a synergistic activity. There is complementarity of action between different substances. If you remember, the immune system is a sort of balance. So when we have, for instance, in allergic patients that show Th2 upregulation and Th1 downregulation, when we want to recover the balance, we need to act in the same time pushing down Th2, gamma interferon, and pushing up Th1, interleukin 12. If you use them combined, you will have a faster result because of the synergistic activity between different cytokines. 7, we learned that if you don't prepare in Guna laboratories according to the sequential kinetic activity pharmaceutical procedure, these low doses, they will be not effective. Only if you prepare the aqueous vehicle, they will be effective as well as the high dosage, but without the side effects of the high dosages, for instance, of interleukins. 8, we learned the clinical safety because, first of all, my friends, he is in Latin, primum non nocere. This is something that always we measure. In all the 9 clinical trials, which are controlled clinical trials, we had 100% of tolerability and couldn't be differently because we are reproducing Mother Nature, and Mother Nature is never wrong. Clinical safety. Otherwise, believe me, on my kids, never I would have used these medications. Instead, I use on them, and they are 2 beautiful guys. 9, affordable costs. We think that this medicine must be a right for everyone in this world, not only for rich people. That's the reason why, with an ethical approach, we decided to keep low the prices of these medications, especially if you compare them to the conventional drugs that can be the comparison medication. I will show you some data also about this. So this is what we learned. But let's go see the first 2 topics, the first 2 points. And I'm very happy to show you about overlapping approach and long-term treatments, our model using single cytokines in rheumatoid arthritis. In rheumatoid arthritis, by an immunological point of view, this is the picture of your patient. We always have an upregulation of T helper 1 subset responsible mainly of inflammatory processes. They are the guys producing interleukin 1, trigger of inflammation. Interleukin 6, marker of chronicity. But unfortunately, in rheumatoid arthritis, as well as in every autoimmune disease, you also have an upregulation of Th17. These subsets of T helper lymphocytes was discovered by Cook and Bettelli in 2006 and 2007. They isolated Th17 for the first time from beta cell of Langerhans islands in diabetes patients, pancreas. Th17 produce a big quantity of interleukin 17 that is, together with TNF-alpha, not only a very strong pro-inflammatory cytokines, but it is also able to destroy tissues. Interleukin 17, together with TNF-alpha, destroy, for instance, cartilage and subchondral bone. So we need to keep under control these 2 guys. Unfortunately, in your patients with autoimmune diseases like rheumatoid arthritis, you have a dramatic downregulation of Th2 and Treg. Do you remember? These 2 subsets are involved in immunomodulation, but they are so low that they cannot more immune modulate Th1 and Th17 overexpression. So, which will be our approach according to low-dose medicine? To push up the activity of Th2 and push down Th1 and Th17. Do we want to translate in another language what I just told you? We need to tell Th1 and Th17, hey guys, please, take it easy, relax. And we need to tell Th2 and Treg, hey guys, wake up, please, don't be so lazy. But how can I tell Th1, take it easy? In Italian? No. In English? No. In Spanish? No. The only language Th1, Th17, Th2, Treg understand is the language of signaling molecules. For instance, interleukin 10 is translated in the language of cell, hey, Th1, take it easy. So, starting from this concept, we prepare a protocol for rheumatoid arthritis. And the protocol, in order to recover the balance between Th1 and Th17, Th2 and Treg, is to counteract the storm of pro-inflammatory cytokines, interleukin 1, 6, TNF-alpha, and 17, with their antagonistic cytokines. And they are interleukin 10, which is especially the antagonistic cytokine for interleukin 6. Interleukin 4, which is the specific antagonistic cytokine for interleukin 17. Actually, interleukin 4 is able to downregulate Th17, which are those ones producing interleukin 17. And we also use a low-dose monoclonal antibody against interleukin 1, a sort of canakinumab, in order to block interleukin 1. So that is the rationale that we follow to keep low the disease activity in rheumatoid arthritis patients. This is an open, randomized, active control. You will see which is the active control. Clinical trial with low-dose SKA cytokines. Please, my friend, look the language we are using to talk about our medications that, by a regulatory point of view, are registered as homeopathic. But a journal like Drug Design, Development, and Therapy never will publish a trial speaking in terms of homeopathic dilutions. Low-dose SKA cytokines versus DMARDs, disease-modifying anti-rheumatic drugs, two classes of DMARDs. Biological DMARDs, which are the monoclonal antibody, for instance, anti-TNF-alpha, Humira, or conventional synthetic DMARDs, the most famous is methotrexate. So we are comparing an homeopathic medication, if you like the term homeopathic, with DMARDs. It was very challenging, this study. Evaluating low disease activity maintenance in patients with rheumatoid arthritis. Please, evaluating low disease activity, LDA, maintenance in patients with rheumatoid arthritis in remission. They enrolled patients with rheumatoid arthritis, severe rheumatoid arthritis, and for definition, they had to be treated with monoclonal antibody, anti-TNF-alpha. The problem is that you cannot use anti-TNF-alpha monoclonal antibodies for more than 6 to 8 consecutive months. Once you stop the monoclonal antibodies, the disease activity immediately goes up. So you need to pass to the second class, the conventional synthetic DMARDs, methotrexate. Or if the patient is a good responder, you can also try to keep low the disease activity through corticosteroids. But both DMARDs and corticosteroids have severe side effects. So what they did is that divided the patients in two groups, Group A and Group B. Group A was treated for 6 to 8 months with monoclonal antibody. Group B, as well as Group A, 6 to 8 months monoclonal antibody. Both groups were in remission. Group A, in order to keep low the disease activity, continued the treatment with the association of GUNA anti-interleukin 1, GUNA interleukin 10, GUNA interleukin 4 for the reasons I told you 5 minutes ago. Group B, after remission, continued the treatment with DMARDs, exactly with methotrexate, normally 7.5 to 15 milligram per week. And let's go to see the results, because really they are quite amazing. In terms of eligibility criteria are the usual ones according to the American College of Rheumatology. Treatment was for 12 consecutive months using 20 drops each for every GUNA medications. 20 drops of anti-interleukin 1, 20 drops of interleukin 10, 20 drops of interleukin 4. Every day for 12 consecutive months. The other group, 7.5 to 15 milligrams of methotrexate. And we measure a lot of endpoints. First of all, the disease activity and the inflammation parameters. These are the results. All right, perfect. The maintenance of low disease activity at the follow-up 12 months is obtained respectively in 67.7% of patients treated with low-dose cytokines, Group A, and in 42.1% of patients treated with DMARDs, Group B. Do you understand? More patients treated with low-dose medications had better responses. This is something huge because maybe from, I hope, Monday, part of your patients with rheumatoid arthritis can be treated this way. I'm not telling you not to use in the first 6 months to approach the patients Humira. You need to do that. If you use low-dose cytokines in the first 6 months, maybe they are not sufficient, unless you are so good to take the patients in the early stage of the disease. Look that if you approach every disease in the early stage, low-dose medicine is the first option. If, unfortunately, is not more early stage, but a consolidated stage of disease, you need to give a punch with the monoclonal antibody, and then pass to the low-dose treatment. Specifically, the primary endpoint was the DAS28, Disease Activity Score. In other terms, you measure the inflammation and the function of 28 joints. Please look, the blue column is the group treated with GUNA low dose. Red column, DMARDs. You can see that even though there is not a superiority by a statistical point of view, because the standard deviation is quite big, we can say that it's more effective. We also measure the CDAI, that means Clinical Disease Activity Index, is an algo-functional index, and SDAI, Simplified Disease Activity Index, which is a sort of summation between this one and this one. In all these indexes, always the blue column is lower. That means low-dose treatment more effective. What is interesting is that the group treated with the cytokines reach the primary endpoint before the group treated with DMARDs and keep lower the disease activity. You can see the delta. This is huge. This is really huge. Just to give you an idea of the new paradigm of low-dose medicine, in a couple of months, that journal, Drug Design and Development, had 4,500 views. Never in the history of the journal they had so many views for a paper. What does it mean? That the world is looking at us, is looking at you who are using this kind of medications. Also, the secondary endpoints were, more effective for group A, low-dose group. Pain Visual Analogic Scale, the VAS for pain, you can see, blue column. Global Health Assessment, Quality of Life, and for me, so very important because they cannot be interpreted. They are number. Erythrocyte sedimentation rate and C-reactive protein. Always not inferiority, I can say a little superiority for the group treated with low-dose cytokines. And we are not comparing low-dose cytokines to an ointment of arnica. We are comparing with DMARDs. It's important because it's easy to win easy. Okay, I compare low dose with meditation. Okay. Look, that meditation is very important. Meditation is able to keep down interleukin-6. And interleukin-6 is the marker of low-grade chronic inflammation. It goes up with stress. A beautiful paper published in 2013 measured the difference in the expression of interleukin-6 in two groups, Japanese able to meditate and Americans from New York, Manhattan. Who is the group more stressed? Easy to understand. And you see the expression of interleukin-6, which remain flat in Japanese and in New Yorkers goes up. So meditation is an anti-inflammatory medication. But DMARDs are more effective than meditation. So that's the reason why we compare our medication with the gold standard. It's challenging to compare to the gold standard. Other secondary endpoints, you know that according to the ethical committee, you have to give the possibility as rescue therapy, this patient to take painkillers. In that case was Celecoxib and NSAIDs, 200 milligrams per day when they need it. No difference in the two groups. And also safety assessment, no adverse effect were reporting by investigators in both groups, included our group. So I can tell you 100% of tolerability in this study and also in the other 8 clinical trials. Just to wrap up, this is the protocol used in this study. 20 drops each medication once a day for 12 months. Look, that is important to keep on going. But it's the same patient that very often doesn't want to interrupt the therapy because definitely he stay well. in order to increase the compliance of the patient, I recommend you also the technique of the bottle of water. Instead of to take every day 20 drops sublingually, 20 drops, 20 drops, the patient every morning prepare a little bottle of water like this with 20 drops of each product. And during the day, it drinks this therapeutical protocol. This is the best way in terms of compliance, because of you oblige the patient at least to drink a bottle of water, and we need to keep hydrated the extracellular matrix because it's so important for us. And also remember that for every low-dose medication, including homeopathic medication, is more important the frequency of administration than the quantity in one shot. So several times it's better than one shot time, okay? If you prefer in terms of the triangle of therapy, according to physiological regulating medicine, beside the 3 cytokines used in the clinical trial, I recommend you also these 2 other medications. They are written in gray because they were not used in the clinical trial. But according to the experience of 3 decades, more or less, we can tell you that Guna-Lympho is a very interesting drainant medication. In rheumatoid arthritis, better than Guna-Matrix, because one of the markers in terms of cytokines expression in rheumatoid arthritis patient is interleukin-6. And in Guna-Matrix, we have interleukin-6. So it's better in those cases not to use matrix and to drain the lymphatic vessels through Guna-Lympho. Guna-Lympho has also many anti-inflammatory homeopathic remedies inside, so it's really very good. And absolutely, you need to know and love this medication, which is Guna-Flam. Why it's so important in rheumatoid arthritis? Because by itself, it contains anti-interleukin-1 alpha and interleukin-10, which are 2 of the 3 medications of the protocol I showed you. But I put Guna-Flam in the triangle because beta-endorphin inside. I mean, it's an opioid, beta-endorphin. And remember that beta-endorphin works against pain both on the peripheral and central pathway. Is able on peripheral pathway to take under control the substance P. And on central pathway, just remember that beta-endorphin increase dopamine. And increasing dopamine, you downregulate GABA, which is the neurotransmitter that makes you more sensitive to pain. Instead, dopamine is the molecule of rewarding, of motivation, of sex. Thanks God we have dopamine. Dopamine is the most beautiful. Because dopamine is involved in desire, arousal. That's the reason why we as males are full of dopamine. We cannot see a woman immediately, we lose our mind. You women, you have more oxytocin. That's the reason why you have multiple orgasms. So both women and men are lucky because we are always aroused and you have the possibility of a multiple orgasm. But this is not related to rheumatoid arthritis. We can speak about that after midnight tonight. Okay, good. Please, please, my friend, on your desk always keep in mind Guna-Matrix, Guna-Flam. Because once you detoxify the matrix and once you keep under control acute and low-grade chronic inflammatory processes, more than 50% of the work is done. Okay? It's important the use of gunaflam in order of 10 drops every 30 minutes for 2-3 hours to keep under control the acute symptomatology. Can be fever, can be pain. And then, after 2-3 hours, you go on using 20 drops twice a day for gunaflam. For gunalympho, the same administration, 20 drops twice a day. In this slide, I wrote 2 to 4 months. But believe me, in this kind of patients, it's very important to go on and go on and go on. Because the problem is that once you stop the therapy, the disease goes up again. The problem is that if you use methotrexate, you destroy the patients at the end. Okay? Oh. This is a beautiful, this is a gunalympho. I told you it's interesting as drainant medication, but also remember that because of the presence of calendula, phytolacca apis, apis also edema, not only is a lymphatic drainant, but it is an anti-inflammatory medication. This is huge, for instance, also in kids with adenoidal hypertrophy. So we prefer to consider lymphodem matrix in rheumatoid arthritis. Do you have patients with rheumatoid arthritis? Yeah? Okay. So please, give me the satisfaction and also give me a sense for my life, sharing with you this information. Maybe in Colombia, starting from tomorrow, some patients will be cured in a new, effective way. This is the reason of my life, but also your life. So we need to be pragmatic in this moment. Point 3, filling the therapeutic vacuums. Unfortunately, we have many diseases where we don't have a recognized effective therapy. So why not to work on that direction? For instance, I know that Felipe, my friend Felipe Torres, Dr. Torres, spoke about the orphan diseases on Friday. I'm not speaking about orphan diseases, but there are a lot of diseases without any recognized effective therapy. And I'm very happy to share with you this study published on Immunology Letters. If you are involved in immunology, you know that this is one of the most important journals in immunology in the world. And this study has been performed by the pediatric department of the University of Pavia. That is the most important pediatric department of all the universities in our country. I know exactly what I'm saying because my father was a professor of pediatrics, and I know that Pavia was the referring point for every university in our country. Once again, how important it is to perform studies with the top professors, because no one can tell them this is fresh water, because they are the super professors. By a political point of view, it's important to invest in that direction. Oh, this pointer. Okay, so what can we do to help these little kids in terms of modulation of their immune response? But first of all, we can do very well because the immune system maturates very slowly. More or less, we are at the top of the maturation between 10 and 12 years of age in these kids. So, since we are whispering to the cells, we are still in time to re-educate cells to be, for instance, not too lazy. I'm speaking about some immune cells. By an immunological point of view, this is the picture of these kids. Please take a look of this picture because it's really important. You have an upregulation, especially of interleukin-10, which is a great cytokine to keep under control chronic inflammatory processes. But when upregulated, it has a super immunosuppressive cytokine. So these kids have interleukin 10 too high and immunostimulating cytokines too little. Especially remember this cytokine, which is interferon gamma. Interferon gamma is the turning point in kids for immune response. As well as in elderly people, the most important immunostimulating cytokine, as you will see, is interleukin 2. But in kids, no question. They have a lack, a deficiency in gamma interferon. Epidemiology. And it's something huge. I don't know in this beautiful country because the weather is better than in northern Italy. But in Italy, he's really a problem, respiratory recurrent infection. Under 5 years of age, about 20% of population suffers for RRI. 1/3 of pediatric consultations and 8 to 18% of hospitalizations are due to recurrent tonsillitis. 25 to 45% of children with recurrent respiratory infection needs surgery, especially adenotonsillar hypertrophy is the diagnosis. I mean, almost 50% of them. So it's also a big problem for the health system. In terms of diagnosis, to classify that kid as a kid with recurrent respiratory infections, he has to have at least 6 infections per year. Per anno, per year. And to be more precise, 6 infections between September and April. Where is the tragedy, my friends? How are they treated? Amoxicillin and clavulanic acid. Okay 1 time, okay 2 times, but 6 times per year means really to compromise the immune system. If they need the antibiotic treatment, my God, first option, if they have plaques, for instance. But in the recurrency, we need to strengthen the immune system, not to keep down it. In terms of therapy, mainly symptomatic, corticosteroids and acetaminophen, paracetamol also called, and by a prophylactic point of view, antibiotics. In our country, the first choice is amoxicillin plus clavulanic acid. Bacterial lysates, but now the European Union avoid the use of bacterial lysates. So, what can we do for these kids? These are some pictures of tonsillar hypertrophy. You can imagine these kids. They have night apnea. I mean, it's a problem. It's a big problem. So we need absolutely to try to help them. Once again, if you like the image, I like it so much because scholastically it's very clear. This is the problem. Poor gamma interferon. Why gamma interferon is so crucial? Not only... I think there is a problem. Houston, we got a problem. I think I have this part. Okay, I don't know if it works. Excuse me, let me see. Yeah. I would like to know who is the guy who put this marker. Okay. I think with alcohol, okay, will vanish. If someone can tell some attendant to take some alcohol to clean the blackboard would be nice. Anyway, look at this, the right size of the moon. Why gamma interferon is so important? First of all, because as all of us studied, he is able to inhibit the replication of viruses. But even more, please remember this passage, interferon gamma is the stronger activator of CD8 plus immune cells. When gamma interferon stimulate CD8 plus, they differentiate themselves in T cytotoxic cells. T cytotoxic cells are the most important immune cells involved in cytolysis. For instance, a cytolysis of a cell infected by a virus. So, T cytotoxic kill the cell infected by the virus. If you have a good number of T cytotoxic, immediately when a virus will penetrate in your cell, you will kill it. If you don't have enough T cytotoxic cells and also natural killer cells, the cell infected by the virus will be the perfect pabulum for the replication of the viruses. This is the mechanism induced by gamma interferon. These kids normally have low level of gamma interferon in their immune system. This is the paper in order to sustain what I told you. American Journal of Respiratory Critical Care, 2004. Reduced production of gamma interferon in the first year of life is related with number of viral infection. You can see that just one circle of gamma interferon, 6 infections. Many circles of gamma interferon, 0 infections. So, among all the cytokines in pediatrics for respiratory recurrent infections is gamma interferon, no doubt. This is the medication tested in this study. Please fall in love with cytomix, because if Gunamatrix clean, Gunaflam keep under control inflammation, cytomix strengthens the immune system. You already know the mechanism mediated by gamma interferon activating CD8 plus becoming T cytotoxic cell. Cytomix that contains gamma interferon stimulate gamma interferon to stimulate CD8 plus, but also stimulate natural killer cells, which are big producers of gamma interferon, to produce autologous gamma interferon. So, from one side, with cytomix, we provide a good quantity of gamma interferon. From the other side, we stimulate natural killer cells to produce their own gamma interferon. It's really an amazing medication. You already have seen the structure. You remember some plants with anti-inflammatory activity. A group of Swiss organ preparations specific for immunocompetent tissues in order to keep under control inflammation in lymphoepithelial tissues, and also in order to keep alive the immune system. Perfect, in the best moment. You all right. Okay. Block this, otherwise I will go on the other side of the stage. Okay. What are you doing? Well, the camera. The camera. Okay, good. Oh, we are a big family, eh? Okay. Okay, please. No, you know what? Please, did you take the black one? Okay, good. Just in case. Okay. So, anti-inflammatory activity, immunostimulation of the immunocompetent tissues, and the group of cytokines. So, please look. We have GCSF, granulocyte colony stimulating factor. A growth factor able to stimulate granulocyte. So, quick response. Interleukin-1 beta and interleukin-6. Are they good or bad? Why? Neither. They are involved in inflammation, right? So why you say they are not bad? They are involved in inflammation when they are upregulated. But when you provide in physiological concentration, they are the most effective immune-stimulating cytokines. And especially interleukin-6 does that. So we are giving physiological concentration of them. Obviously, we are providing gamma interferon. And interleukin-2. Interleukin-2 is the most specific interleukins. It has a pleiotropic activity. It is able to stimulate the clones of Th1, Th2, Th17, Treg. I mean, all the immune system. And super interesting is the presence of low physiological dose of interleukin-4, because keep in mind, interleukin-4 is the strongest activator of dendritic cells. What does it mean? That thanks to this interleukin, the kid will have super dendritic cells able to process the virus, presenting the virus, the antigen of the virus, to the CD4 naive. I mean, is absolutely crucial, the passage through the antigen-presenting cells. And the most important one, which is the dendritic cell. You understand how we formulated these medications, starting from the pathophysiology and rebuilding the passages into the medication. Beautiful medication. It is in granules. I will tell you which is the direction, in granules. So kids love cytomix because the granules are saccharose granules. So they are sweet and they love them. Guna laboratories are very attentive to the quality of the product. So thanks to a specific technology, we are able to make our granules based only on saccharose and not on lactose. If you take any homeopathic granule, the core is lactose. The surface is saccharose. The problem is more and more people are becoming intolerant for lactose, so they can have problem. So we find, after many years of researches, to find a way to have the same quality only with saccharose. And kids love that because it's sweet. Well, this is the paper. Low-dose multi-component medication. Do you think that immunology letters would have published if we would have written cytomix homeopathic medication? Forget it. Low-dose multi-component. Everybody accepts it. They say, cool, low dose. And sometimes they ask us, what does SKA means? And we answer, sequential kinetic activation. My God, is the dynamization, more or less. It's not completely the dynamization because we treat the water in a specific way, which makes this water a superconductor. But the language is fundamental. Modulates both humoral antibodies and cellular T cytotoxic cells immune response in an ex vivo study on children subjected to adenoidal surgery. Okay, these are the inclusion criteria, and the exclusion criteria are always the same. What is important that those kids were not in very good condition because they were candidated to surgery. It means that their hypertrophy was a severe hypertrophy, sign of a severe immunodeficiency. The study was conducted on 50 pediatric subjects, 35 males, 15 females. All of them 6 years old as average, starting from kid having 3 years till 12 years, with recurrent respiratory infection. It's interesting because they took the adenoidal stroma. They underwent to mechanical crashing in order to isolate AMC, which means adenoidal mononucleate cells. Adenoidal mononucleate cells. And on those cells, they evaluate the cytokines panel, interleukin 6, 10, and gamma interferon. IgA, pediatricians know how important they are in those kids, IgG and IgM, and the characterization of subclones of B lymphocytes. Believe me, by an immunological point of view, it's impossible to design a more complete design than this. Results. I'm very proud to show you how low doses can be so effective. B cells, the light gray column is the placebo, dark gray cytomix. B naive, B able to switch, B switched. That's very important because we understood that cytomix act on the complete differentiation process of B lymphocytes. Naive, able to switch, and switch. Only when they are switched, they produce through plasma cells immunoglobulins. But to become B switch, they have to pass through able to switch starting from naive. It's absolutely important, even more important when you investigate the activity of a drug like cytomix in a pediatric group because of the immune immaturity of these kids. So it's important, all the passage. You can see 1 dot, the 2 dot, 1 dot, 2 dot. It means that statistically, the P is always below 0.05, statistically significant. Gamma interferon, no words. Look the difference between placebo and cytomix. After 3 days and after 10 days, you have the shot after 3 days, but you keep having a big level of gamma interferon also after 10 days. Gamma interferon, something which is not related with this trial, but letter of nature. Unexpected role of interferon gamma in regulating neuronal connectivity and social behavior. Social behavior. Can you tell me a typical disease where the social behavior is inhibited? Autism spectrum disorders. They are speculating the role of gamma interferon in autistic kids because you can see gamma interferon, the relationship with social and psychostimulation. Gamma interferon, 30 years ago, I studied gamma interferon has inhibition of virus replication. gamma interferon is so important. So, can be cytomics interesting together with Gune awareness that we will study later in autistic spectrum disorders? Sure, sure. This is letters of nature, I mean. And cytomics increases so much the expression of gamma interferon. Interleukin 6, always the dark gray cytomics. Please remember that interleukin 6 has a sort of Janic activity, sometimes good, sometimes bad. But when it's good, it is crucial, has trigger of anti-infective immune response. So we need absolutely to have an increase, always in the homeostatic physiology range, in the concentration of interleukin 6. Interleukin 10, cytomics keep down interleukin 10. And it is absolutely good because interleukin 10 is used by viruses. Look that they are really smart. They use interleukin 10 as an immune escape. They use ourselves to survive. In which way? When a virus goes inside of your body, he makes your body producing interleukin 10. Interleukin 10 has an immune suppressive activity, so the virus said, hey, let's go party. That's fine. So we need to counteract interleukin 10 because of the immune escape used by the viruses. And you have a downregulation. So it's really perfect. It's perfect. By an immunological point of view, cytomics is absolutely perfect. So interleukin 6 and gamma interferon downregulate interleukin 10. Last but not least, the expression of immunoglobulin. You can see that we have a significant increase of IgM, the first antibodies, and especially IgA, the importance of secretory IgA. And we have a lowering level of IgG. It is normal because of the isotypic switch. Since the plasma cell is producing IgM and IgA, IgG goes down. It's very important, the data of IgM, because always we thought of cytomics as a preventive medication. Instead, since IgM are immediately raised, it works perfectly, I will tell you the administration way, in acute infections, together with antibiotics or sometimes also alone. Interleukin 6 especially stimulate the production of IgA, where interleukin 4 especially the production of IgM. So the panel is complete. Directions. In recurrent respiratory infections, and I think that also in your country, maybe a little less, but for sure this is a problem also of Colombian kids, we are used to recommend 5 granules a day, every day, for 3 consecutive months. So easy. Every day before school, 5 granules under the tongue. Treatment of acute symptomatology. If you look at my briefcase, I always have cytomics with me because traveling everywhere in the world, sometimes airplanes and whatever, I go down, I take 10 granules, 2-3 times a day for 2-3 days, and those symptoms typical of early stages of infections disappear. But it's important to increase the quantity. So please, in the name of children, consider this type of prevention. This is the study performed before that one I show you. And it was a comparative study between cytomix and bacterial lysate in the prevention of respiratory recurrent infection. In that case, more than 200 kids were treated, group A with cytomix, group B with bacterial lysates. More or less female and males, same number. You can see the number of acute respiratory tract infections. Group A, cytomix, group B, lysates. The delta is 0.89 in favor of cytomix. Days of fever, an average of 5 days versus almost 9 days. Cycles of antibiotics, 0.39 versus 1.43 in favor of cytomix. It means that these kids don't have to destroy the microbiota and blah, blah, blah. IgA expression, group A, 25% increased versus 16 bacterial lysates. Important, days of absence from school. You can see group A and group B, the delta is 5.49 days difference. So really, this is a super studied medication, 100% of tolerability. You can avoid the chronic consumption of antibiotics, which is a drama in our country. The Italian Association of Pediatricians are really desperate because there is a misuse and abuse of antibiotics, and we can really reach great results. Look that cytomix is not only a pediatric medication. Adult and elderly people can use it. I use it, and it's great. Okay, recourse to surgery, so less surgery in the group treated with cytomix once again. In terms of complete possible PRM protocol, cytomix, 5 pellets twice a day. Guna lympho, you remember, because of the presence of anti-inflammatory remedies for lymphoepithelial tissues. And please take under consideration this medication, Guna anti-interleukin 1. It is our acetaminophen, our paracetamol. Is important in order to control the spike of fever that sometimes these kids can show. The use of 5 drops every 30 minutes for 2-3 hours. And you can avoid the use of acetaminophen. Guna anti-interleukin 1 has to be considered by you as our anti-fever, anti-pain medication. It's used with great success, for instance, by dentists in order to keep under control pain in dentistry. Beautiful medication, Guna anti-interleukin 1. What can we do for elderly people? Do you remember which is the cytokine primarily involved in lack of immune response in elderly people? For kids was gamma interferon. For elderly people is interleukin 2. So if you have your grandfather and you don't want him to be sick, you have to help his immune system providing interleukin 2. Remember, interleukin 2 is already inside of cytomix, but in Colombia you also have available the single Guna interleukin 2. So you can combine cytomix and Guna interleukin 2 in elderly people. Okay, why interleukin 2? Because it is, as I told you, pleiotropic. It activates monocytes, T helper cells, B cells, T cells, natural killer cells. It's normal during elderly that all the immune system goes down. The problem is that the immune system goes down, endocrine system goes down, central nervous system goes down. So we need to give support to these subjects. Interleukin-2, in terms of immunology, is so important. Once again, you can see how he is active on all the subsets of TH, for instance. This is interesting. I am 57 years old, so I am here. Look, interleukin-6. Interleukin-6 is the marker of low-grade chronic inflammation, which is that bastard inflammation that you are not aware to have it, but is there and is destroying your tissues. If you are in healthy condition, the level of interleukin-6 till 50 years is almost flat. After 50, even though you don't have any chronic disease, interleukin-6 starts going up. And we died because of interleukin-6. Unfortunately, as interleukin-6 goes up, interleukin-2 goes down. So here is the problem, that we are even more immune depressed and even more inflamed. So does it make sense in elderly people to give interleukin-2 plus gamma interferon as primary prevention? Absolutely yes. By an immunological point of view, that's the goal. So these are the directions. 20 drops twice a day for a prolonged period of time. Remember, the best way is under the tongue, 30 seconds before swelling. Very interesting is the association Cytomix plus Guna interleukin-2. Cytomix, 5 pellets a day. Interleukin-2, 20 drops twice a day. 3, 4, 5 months. Then a stop of 1, 2 months, and again with another cycle of therapy. In terms of immune control, this is really a very interesting approach. Let's go changing the topic. And I want to show you another interesting study we have performed, and we are impressed in Frontiers in Neuroscience about the use, and the results are really amazing. I will show you all of them, about the use of Guna BDNF, brain-derived nerve factor, which is the most important nervous factor able to keep plastic the brain. And this study has been performed measuring the effect of BDNF on isolated cortical neurons and astrocytes, and in a model of Alzheimer's disease in mouse. So we have a complete panel of data now. So we are going to act on the upper part of the PNEI axis, central nervous system and autonomic system. And we need to be very careful with the role played on the central nervous system by stress. This is a nice slide. When I speak in terms of stress, I'm not only thinking of psychological stress. Also, food stress is important. And stress affects all the part of our body, even though the biggest part is for sure the digestive system. But the brain, the heart, the gut, muscle, everything is affected by the stress. I don't want to tell you anything about the HPA, hypothalamus, pituitary gland, adrenals, which is the highway of stress, the result is the hypercortisolemia that we see very often in this patient under stress. Now we need to create a link between stress and inflammation, because inflammation is the cause of Alzheimer's. And we know also which are the cytokines, markers of that kind of inflammation in Alzheimer's disease. The hyperactivation, this is interesting before arriving to the possible treatment for Alzheimer's. The hyperactivation of the HPA axis, the stress axis, conducts to the upregulation of ACTH and cortisol. Everybody knows that. But not all the people knows that stress downregulates 5-hydroxytryptophan, which is, as you know very well, the precursor of serotonin. That's the reason why there is a so tight link between stress and major depressive syndromes. And why in Alzheimer's always we face also depressive syndromes. So it's really very interesting to start from this part of the cascade. This is an interesting slide because it opens a new universe. What does it say? The hyperactivation of the stress axis conducts to hypercortisolemia. That is important in dementia because hypercortisolemia downregulates the expression of neurotrophic factors, including BDNF, less neuronal repair, apoptosis of nervous cells, dementia. But unfortunately, the hyperactivation, this is the link between stress and inflammation. The hyperactivation of the HPA axis conduct to conditions of low-grade inflammation. Stress and low-grade inflammation. Interleukin-6 is the marker of low-grade chronic inflammation. Interleukin-6 is the interleukins which goes up under stress condition. Look that we can die for stress. But when I ask, how can I die for stress? I die because of inflammation provoked by stress. And we know which is the bastard, interleukin-6. Thanks God we also know how to take under control interleukin-6 with a specific antagonistic cytokine that I'm going to tell you. This is a slide for the New England Journal of Medicine about the role played by interleukin-6 all over the body when we have a focus of low-grade chronic inflammation. I love this slide. Unfortunately, it's not mine, New England Journal of Medicine. What does it say? If you have a patient with knee osteoarthritis, the problem is not of the rheumatologist or the orthopedician. The problem is of the general practitioner. Because from this site of low-grade chronic inflammation, we have the spreading of interleukin-6 all over the body, impacting the vessels, heart attack, arteriosclerosis, the brain, dementia, the bone, osteoporosis, the muscle, sarcopenia, always because of interleukin-6 overexpressed. In this case, overexpressed because of stress. We are a network. We don't have to think in terms of reductionism. So, come back. Which is the link between stress, inflammation, and depression? I love this passage. Interleukin-6, among the thousands of things that it does, also activate two enzymes named IDO and TDO. IDO means 2,3 indolamine deoxygenases. TDO means tryptophan deoxygenases. Maybe you are thinking, okay, Alessandro, why I have to care about IDO and TDO? You have to care a lot. Because these two enzymes, when activated by interleukin-6, shift the good pathway, tryptophan, 5-hydroxytryptophan, serotonin, in the pathway of kynurenine. Kynurenine is a fake serotonin, but with an affinity for serotonin receptors higher than serotonin. So, under stress, you produce IDO. The consequence is the production of kynurenine. Kynurenine occupies the receptors for serotonin, and where your good serotonin arrives, it finds the receptors occupied. Not only kynurenine is a fake serotonin, it also has a neurotoxic activity, especially at the level of the hippocampus. So, in depression, even major depressive syndromes, we need to take under control the inflammatory processes. That's the reason why the scientists of the Mount Sinai in New York in 2016 published this paper. The title, Integrating Interleukin-6 into Depression Diagnosis and Treatment. SSRI are not more sufficient if you don't close the faucet of inflammation, if you don't block interleukin-6. Mount Sinai in New York says that. So, this is the direct correlation between interleukin-6 and depression. Is it possible to downregulate interleukin-6 according to the language of cytokines? I mean, which is the antagonistic cytokine of interleukin-6? Guna interleukin 10. It's not crazy to use Guna interleukin-6 in depression, because depression is an inflammatory disease. You have interleukin-10 in Guna-Flam. So think of Guna-Flam in overlapping with SSRI of your patients if they are using them, or other treatments. But you need to close the faucet of inflammation in those patients. No questions. So this is our proposal for this kind of disease. Guna interleukin 10, here in Colombia you don't have the single interleukin 10, so immediately shift to Guna-Flam. 20 drops twice a day for cycles of 2, 3, 4 months. Guna matrix, why is it important, Guna matrix? Not only because those are patients completely toxic, because they will arrive to you after years of use of SSRI, but even more because maybe you remember that Guna matrix contains the hydroepiandrosterone. So it gives energy to those patients. Okay, DHA. Maybe we need to investigate more the role of DHEA, because in menopause is so crucial to protect the brain. In depression is so crucial. A reason more to love Guna matrix. Guna mood, which is our symptomatic medication. Please take a look at this medication because it's another important product. Tryptophan, hydroxytryptophan, serotonin. So you don't give only serotonin but also the precursors. Very interesting is also the presence of sepia and ignatia, that in homeopathy are two of the most important antidepressant remedy. Sepia for women especially. In men, the homologous is Lycopodium. Very interesting is also the presence of lachesis, muta, and salix. They stabilize the neurovegetative system, and they act so well in hot flashes during menopause. So it's easy to understand why guna mood is so used in premenopause and menopause, from one side to stabilize the mood, from the other side to take under control the hot flashes. But today I just want to give you an intriguing aspect of guna mood. It works unbelievably well in patients with craving for carbohydrates. Maybe you have them. Oh, doctor, I need to take sugar. Why? Because there is a mysterious link between insulin, sugar, tryptophan, and brain. Insulin is not only the carrier for sugar, glucose, but it's also the carrier for tryptophan inside of the neurons. So why your patient is craving for carbohydrates? Because eating carbohydrates, you need to produce more insulin, but producing more insulin, you take inside of the neurons tryptophan, and you feel well. So, thanks to guna mood, which contains tryptophan, we are providing more tryptophan, and you don't need to be addicted to insulin. That means to be addicted to carbohydrates. Do you understand this passage? It's interesting, eh? And look, there are a lot, especially women. I crave for carbs. I crave for sugar. Okay, disassuefaction through guna mood. Interesting, absolutely interesting. All right, this is the reference for those of you who are interested to this. Look at these slides. I share everything with everybody. So if you need them, you just have to ask me. Question for you. Where do you find, in which kind of patients, you find the co-presence of pain, fatigue, depression, fibromyalgia, also in cancer actually, but especially in fibromyalgia. Also in fibromyalgia is crucial the role played by interleukin-6, provoking pain. And it's interesting that until 10 years ago, the most part of the scientific community was used to consider patients with fibromyalgia as hysteric and putting them under antidepressant. They were not hysteric. They were inflamed. Thanks to some brain mapping technique, they recognize some area of perivasal inflammation always in the same area of the brain in patients with fibromyalgia. That's the reason why in those patients it's sufficient to provoke pain in the trigger points, a pressure of 2.4 kilograms per square centimeter. In people without this problem, to provoke pain in the trigger points, the pressure must be 4.16 kilograms. If you go to see which are the substances overexpressed in this area, you will find interleukin-6 and VEGF, vasal endothelial growth factor. Is it good or bad? Neither good nor bad. If you have VEGF in an homeostatic concentration, that's good for the neovascularization. But if you have plus, like in these patients, it has a pro-inflammatory activity stronger 1,000 times than histamine. So you can imagine. The problem is inflammation, inflammation, inflammation. These are the trigger points, okay? What can we do for these patients? Guna interleukin 10, or here in Colombia, Guna flam. 20 drops twice a day for long time, not less than 3 months. Otherwise, you don't see real results. Guna flam, interesting, the administration of 10 drops every 30 minutes when the patient has pain is the rescue therapy, all right? So here in Colombia, every day, 20 drops twice a day. When they need it, 10 drops every 30 minutes. Guna matrix, Guna flam for beta endorphin, sorry. Why Guna matrix is important here? Not important, super important. Because the trigger points are extracellular matrix. And when you do the palpation of the trigger points, you feel a fibrotic tissue. Do you remember that Guna matrix was able to counteract the fibrosis? So it's absolutely mandatory the use of Guna matrix. Last but not least, also consider Guna sleep, because one of the typical symptoms of fibromyalgia is sleep disorder. Actually, we don't know if is the sleep disorder provoking pain, or is the pain that don't allow you to sleep well. What we know is that, I'm sorry, this is in Italian, is that sleep disorders downregulate growth hormone, downregulate the active metabolite of growth hormone, which is insulin growth factor 1, and you have alteration in the muscle tissue. So maybe it's the sleep disorder provoking pain more than pain not making you sleeping well. In order to make the patient sleeping better, this is our regulator of sleep named Guna sleep. It's very easy to understand why. Melatonin, serotonin, pineal gland, first of all. Okay, you don't have to be a genius to put also in the multi-component chamomilla, melissa, and avena sativa. But especially these components are active. Guna sleep is interesting. In terms of administration, I recommend you 20 drops in the morning in fibromyalgia and 20 drops 30 minutes before going to sleep in order to accompany the patient to dreams. Okay, good. Carlos, can you tell me when we will have the break? 4 o'clock? Okay, perfect. So, do you resist other 15 minutes before break? During the break, will you drink a coffee? Why will you drink a coffee? Okay, you will tell me to stay awake. No, by a molecular biology point of view, why will you drink a coffee? Why homeopathy is important for this? It's interesting, eh? If you study homeopathy by this point of view, you will find a lot of interesting things. Look why you will drink a coffee. This is a neuron. I mean, this is the new neuron of men, one of neurons of women. Okay? There is a prevalence of women in this room. That's the reason why I say that. We have one neuron. We have to keep it well because the neurons, as well all the cells, work because of the second messenger, AMPC. AMPC has to have a control half-life. And Who is the controller of AMPC? Because if it doesn't stop working, AMPC inside of the cell, all the cell will be like this. Not good for them. Thanks God, we have an enzyme named phosphodiesterase. Phosphodiesterase block AMPC. Caffeine, if you use high dosages, what you are going to do, during break, you will drink a cup of coffee. Caffeine is an antagonist of phosphodiesterase. So phosphodiesterase will not block more AMPC, and your neurons will be, wow! Does caffeine exist in homeopathy? Sure. Coffea. When we use coffea? For anxiety and sleep disorder. Why? Because of the hormetic effect, caffeine in low dose, instead of to have an antagonistic activity on phosphodiesterase, has an agonistic activity. So, having a super phosphodiesterase, you block the AMPC before its normal half-life, and the neurons go sleeping. I will be your caffeine high dose for 15 minutes now, because we are going to see something amazing. And maybe we will keep on seeing that after the coffee. All right, interesting, to study homeopathy by this point of view. Hahnemann couldn't know phosphodiesterase. He was a genius because he's understood everything without seeing that. Like Steve Jobs. Those kind of guys able to see something that doesn't exist yet. Already taking the coffee? All right, good. So, I'm going to present our study on Guna BDNF. Don't worry if you don't have Guna BDNF in Colombia, because you have BDNF in Guna Geriatrics and Guna Awareness for kids. So, no problem. I'm quite scared about this. This is the projection of Alzheimer's disease in the world between 2015 and 2050. We are going to have a drama, because Alzheimer's is not a problem for the patient. Maybe the patient doesn't know anything, but for the family is a huge drama. Now we have 47 million people with Alzheimer's. In 30 years, in the world, 131. Please tell me why this not natural trend. Why? Do you have any idea? There is a word. Great. Carlos, always I thought that Colombians are the best in the world. Definitively. Because I ask this question in every country in the world, and no one answers. So Colombians are great. Not only the most beautiful women of the world, as always, but also the smartest doctors. So this is the country. Come on. The second country is Italy anyway, okay. All right. Exactly, my friends. Inflammation. And which is the cause, the main cause of this inflammatory attack we are living? My God, you are genius. Exactly. Food. In fact, you can see Europe, look, from 10 million to 18. America, because especially United States, 9 million, 30 million. Where do you eat better? In Italy or in McDonald's in Detroit? Look Asia. Look Asia. 22 million, 77 million. Do you know why? They are changing their food from rice to McDonald's. I hope no one will be from McDonald's, otherwise they will kill me. So I have a slide later. Take care of your gut. That's mandatory. Anyway, inflammation, no question, inflammation. Let's go inside. Now we know exactly which are the cytokines overexpressed in Alzheimer's. This is the order, TNF-alpha, interleukin-6 especially. And I need, with the following slide, to explain a passage which is crucial to understand this disease. Okay, look, normally in physiological condition, we have in our brain a protein called tau protein, which stabilizes the microtubules. Do you remember the microtubules of the video? Exactly. Tau protein keep them stabilized. What happens when you have high levels of interleukin-6? I mean, you are inflamed because you don't eat well, for instance. That you activate the tau protein kinases, an enzyme that phosphorylates the tau protein in P tau protein. And just this P group, instead of stabilize the microtubules, disorganize the microtubules, producing those that in the United States calls tangles, in Italian gomitoli, tangles of insoluble tau protein. This insoluble tau protein provoke an alteration in the signaling between cells. Do you remember that cells talk to each other through the extracellular matrix? But now you have those tangles of microtubules. So no more communication between neurons, no good. Neurodegeneration, cell death. Everything started here with interleukin-6 and inflammation. That's absolutely important. For many years, we have thought that the problem was the beta amyloid. Maybe a part is due to beta amyloid, but the biggest part is due to these tangles of microtubules. Interesting also, I'm building a sort of puzzle. Also, why this increase of Alzheimer's? JAMA, Journal of American Medical Association, 2013. Please look, proton pump inhibitor and histamine 2 receptor antagonist use and vitamin B deficiency. In this paper, they say that the use of PPI and H2 antagonists for more than 2 years provoke a dramatic increase in neurodegenerative diseases, Parkinson's and Alzheimer's first of all. Why? Because PPI and H2 antagonists don't stop only the production of chlorhydric acid from the parietal cell, but they block also the production of intrinsic factor. And you remember very well that you need intrinsic factor to absorb vitamin B12. And vitamin B12 is like food for our neurons. So take under control your patients under PPI since more than 2 years. For instance, overlapping PPI and Guna stomach. And you can decrease the administration of PPI in order to keep your patient only under treatment with Guna stomach, which is our medication for that. Interesting, eh? Very, very interesting. Stress is very important as cause of inflammation, as we have said, and it's so important the correlation between gut and brain. Everybody speaks about the gut-brain axis, the second brain, blah, blah, blah. But really, you have seen the projection of prevalence of Alzheimer's in the world. please take under control the gut, because gut is a PNEI microcosm. Gut mucosa is able to produce neuropeptides. 90% of serotonin is produced by enterochromaffin cells. Neurohormones and hormones, cytokines. So an alteration in the gut spread out all over the body, and especially to the brain. Stress is mainly involved in the alteration of gut mucosa. This is the beautiful paper signed by Collins and Bersick, published in Gastroenterology 2009. They were the first one describing the gut-brain axis. And they say that stress can alterate the microbiota homeostasis, provoking inflammation in the gut, and with a bottom-up direction, that inflammation from the gut can affect the brain. So this is a vicious cycle: stress, inflammation, brain degeneration. My God. These are the two guys. Everybody has to be thankful if you speak about microbiota, they are the guys. The third element, they spoke about the third element, the microbiota. Just some papers. Alzheimer's disease and gut microbiota modifications. The same in autism, we will see. The microbiome and disease, reviewing the links between the oral microbiome, aging, and Alzheimer's disease. Scientific reports, microbiota modulation counteracts Alzheimer's disease progression. So definitively, if we want to have a global approach to this disease, we need to start also by the gut. The disruption of the gut provoke inflammation. Inflammation provoke impaired intestinal permeability. This slide is because, once again, Mother Nature. Do you know which is the cell of your body with the highest number of receptors for corticotropin-releasing hormone? The goblet cell in the gut. The gut is really the second brain, but it is so delicate for the stress because some of the cells in the gut mucosa, the goblet cells, are full of receptors for CRH. So if you are a little stressed, immediately the gut say, oh my God, something is wrong. If you disrupt the integrity of the gut mucosa, you start with some diseases which are related to gut mucosa integrity disruption. Everything is played at this level of the junctional systems. Okay? Alterated microbiota, inflammation, you break the tight junctions, no more barrier effect, you lose immunotolerance, and you have a chronic inflammation. Chronic inflammation from the gut all over the body, especially the brain. So, I changed this slide from New England Journal of Medicine, and instead of the joint, I put the gut. Just a flash. Always protect the homeostasis of the gut microbiome. We have a specific medication for that. I love it. The name is Ubioflor. It is a multi-component medication. The core is this pool of nosodes, Escherichia coli, Proteus, and Candida. Always for pediatricians, it is very effective again versus rigurgitus, because Etusacinapium, which is very well known in homeopathy, especially for that. It contains also scatolum and indolum, so abdominal bloating, which is one of the signs of dysbiosis. It's very well managed by the presence of these two catabolites. And always our mania to drain, in this case, the gut. Beside ubioflor, in order to keep in homeostasis the microbiota, think of Guna Bowell in order to restore the integrity of the epithelial monolayer of the gut mucosa, especially because of the presence of vitamin D2. Vitamin D2 in low dose, 2x in that case, we are not working in the direction of a vitamin supplementation, but in the direction of this slide. Vitamin D can be internalized by the epithelial cells of the gut, and they activate the protein synthesis of occludins, zona occludens 1, which are the proteins of the tight junctions. So you close the space between the epithelial cells, which is the problem, for instance, in Crohn's disease. Interesting. So it's important to have a global approach to Alzheimer's disease, starting from the gut. Second, keep under control the inflammation, and you already know what to do when you are under attack of interleukin 6. Tell me which is the interleukin to use? Interleukin 10. Or Guna Flam, exactly. Easier to remember, Flam. And now, after the break, please, hey, Guy. Okay? Okay for Eubioflor and Guna Bowell, but even more in Alzheimer's patients, think of, but we will see what to do after the coffee break. And I will show you that beautiful study about BDNF in Alzheimer's mice.